Our next guest is Dan Southard. Is Dan available?
I am, Bobby.
Oh, hello, Dan.
Hello.
So let me go ahead and formally introduce you to our group. Dan Southard is Chief Deputy Director at the Department of Managed Healthcare, where he is responsible for oversight of the day-to-day operation at DMHC. Prior to his appointment, Dan was the Deputy Director for the Office of Plan Monitoring, where he was responsible for evaluating plan regulatory compliance related to quality improvement, utilization management, and member grievances, and ensuring health plan network have right types of providers necessary to deliver healthcare services that meet time and geographic access requirements. On his personal time, Dan developed and patented a medical device to prevent the formation and decrease the healing time for pressure ulcer, which is very important. A really useful device that many of us who end up in a nursing home or in a hospital will develop the pressure ulcer, and this tool is definitely a big help. So without further ado, Dan, the floor is yours.
All right, thank you, Bobby. I'm a little technology challenged, so I'm going to try and share my screen because I've put together a PowerPoint, so bear with me as I do that. So, Bobby, can you just confirm you can see my PowerPoint?
Dan, you're not that technology challenged. We can see.
All right, very good. So thank you. So as Bobby indicated, my name is Dan Southard. I'm the Chief Deputy Director at the Department of Managed Healthcare, or the DMHC. And I appreciate Bobby inviting me today to present to you because the DMHC is an untapped free resource for most Californians that they are unaware of. And so anytime I have an opportunity to share the good work we do at the DMHC, I jump at that opportunity. So I'll start with our mission statement. The California Department of Managed Healthcare protects consumers' healthcare rights and ensures a stable healthcare delivery system. So what I'm going to discuss with you today is I want to give a brief overview of our DMHC operations and with a focus on our help center, and provide you a few examples of how we've assisted through our help center individuals with disabilities get the services or durable medical equipment they are entitled to under their contract or evidence of coverage. Then I'll talk a little bit about the activities of our internal DMHC Disability Advisory Committee and our newly formed DMHC Equity and Action Work Group and how that interacts with our Disability Advisory Committee. And then I'll wrap up with a quick overview of a health equity and quality initiative that is a result of Assembly Bill 133. So moving forward with the overview of the DMHC. So we are a regulator of full service and specialized health plans. So we regulate about 96% of enrollees or consumers enrolled in healthcare coverage that is regulated by a state entity. The remaining oversight at the state level is to the California Department of Insurance. A full service health plan example is Kaiser, Blue Cross, Blue Shield. An example of a specialized health plan is Vision Service Plan or Delta Dental. So we regulate all HMO, which is a health maintenance organization, and some PPO, which is a preferred provider organization, and EPO, an exclusive provider organization products. There are advantages to being in an HMO and disadvantages to being in an HMO, and again, advantages and disadvantages of being in a PPO or EPO product. We regulate some large group products and most small group product and individual products. Examples of a large group would be the state of California. A small group would be a mom and pop business, and individual products are those that you would require through Covered California. And then we also regulate most of the Medi-Cal managed care plans. So the Department of Healthcare Services is the purchaser of healthcare coverage for our vulnerable and poorer communities, and we provide the regulatory oversight for those Medi-Cal managed care plans. So it's kind of a dual role between the Department of Managed Healthcare and Department of Healthcare Services. Again, some examples of the specialized health plans are dental, vision, behavioral health, chiropractic, and prescription drug plans. We also have a very limited oversight for Medicare Advantage plan. So Medicare Advantage plan, when you're eligible for Medicare, you might roll all of your services into a Medicare Advantage plan. Kaiser, Blue Cross, a number of the larger healthcare coverage entities provide Advantage plans. But our oversight for them is for financial solvency only, to make sure they have the finances to pay claims and provide the services to the enrollees they're taking premium dollars from. So we've got 9 offices. The director's office includes our Office of General Counsel, Communications, and Legislative Affairs. Our Office of Plan Licensing is where everything starts. So if a healthcare service plan wants to be licensed in California under our jurisdiction, they've got a number of documents they are required to file, and our Office of Plan Licensing reviews those documents, and then we'll issue a license to a healthcare service plan. Our Office of Legal Services acts as our general counsel for any matters internally, and then also addresses our regulation packages. Our Office of Financial Review, as I talked on the Medicare Advantage, financial solvency, we have to ensure that not only health plans are solvent and have the financial means to pay claims, but also if they delegate any activities to a medical group or IPA, that those entities also have the financial means to pay claims. Our Office of Enforcement does exactly as it would state. Any health plan that is out of compliance with the Knox-Keene Act, which is our body of law, is referred to our Office of Enforcement, and they will either administer administrative penalties and or corrective action plans to bring the plans into compliance. Our Office of Plan Monitoring, where I was formerly the deputy director of, does medical surveys or audits of health plans every 3 years to ensure compliance with the law. But you also look at health plan networks to ensure that health plans have the right number of providers in the right locations to deliver all of the healthcare services afforded to consumers through their evidence of coverage. Our Office of Technology and Innovation and Office of Administrative Services provide support to all of our other programs, and that our help center is probably 25% of our entire staff. And that's where consumers who are having difficulty obtaining care can come to for assistance, and providers can also come if they're not receiving fair payment from the health plans. So our help center, where I want to focus, is assisting consumers with healthcare issues and ensures that managed care patients receive the medical care and services to which they're entitled. We also do this on the provider side. So as I earlier indicated, that if a provider is provided services to an enrollee and they're not being paid on a time or the right amount, they can file complaints with our help center as well. Our help center consists of 4 main divisions: our contact center or a call center. So anyone who calls in can, from any entity, if it's not even under our jurisdiction, we can provide some guidance and then redirect them to the appropriate entity for assistance. Our Division of Legal Affairs and Policy assist our analytical divisions, our Independent Medical Review Branch and Provider Complaint Unit, if there's any legal issues that need to be reviewed as part of reviewing a complaint from a consumer or provider. Our Independent Medical Review and Complaint Branch handles consumer complaints and IMRs. And I'll get into that a little bit more detailed in the next few slides. And again, our Provider Complaint Unit addresses complaints from providers throughout California. So this just is a breakdown of the types of and percentages of consumer complaints we receive. You'll see the number 1 is in the claims financials. So that would be a health plan didn't pay a claim to a provider, and now that enrollee is being billed for that service. So they might file a complaint with us for us to get involved to make sure that that claim is paid. The next most frequent is benefits coverage. So somebody might request a service or durable medical equipment that isn't covered by the health plan. And so that's a complaint we would look at to determine if the health plan is correct in denying that service or was incorrect, and we would require the health plan to cover whatever that request was from the consumer. The next 2 are health plan customer service and provider customer service. These are really quality of care issues. If you were in contact with your health plan or went to your provider's office and they didn't treat you appropriately, you can file a complaint with us. We would require the health plan to send that through their quality review process and maybe follow up with either their health plan customer service staff or the provider which they contract with to ensure they're providing appropriate service to their consumers. Next is access to care. That could be in the disability world that a provider's office didn't have a low-rise table for a consumer to get on. It could mean they can't get an appointment with a provider within the timely access standards. The next is enrollment. If someone is discontinued from their enrollment, cut off from their enrollment inappropriately, we would review that case and we might require the health plan to reinstate that consumer. And then coordination of benefits is a very small section of our complaints. It's really coordinating benefits if someone has dual coverage and they weren't paying for, one of the health plans wasn't paying for their portion of that dual coverage. Independent medical reviews. So as you note here, approximately 68% of consumers who file an independent medical review application with our department ultimately end up receiving the services they requested. And that would either happen through us submitting that case to our independent medical review organization, or based on our getting involved, the health plan reverses their initial denial and approves whatever the service is that the enrollee requested. So how this works is if your health plan denies a service your doctor or you requested, stating it is not medically necessary, it's experimental investigational, or it's non-emergent urgent, it would qualify for an independent medical review. We currently contract with an organization called Maximus Federal Services, and they employ or contract with a variety of providers in different specialty types. And so if we qualify a case for an independent medical review, we send all the documents that we received to the independent medical review and require the applicable health plan to send any medical records or any information they have available respective to this complaint to our independent medical review organization. Our independent medical review organization then assigns that case to an appropriately qualified medical provider who reviews all of the documentation to determine if the health plan's denial of whatever services requested was appropriate or inappropriate. If that reviewer determines that the health plan was incorrect in denying that service, we overturn that decision, and the health plan has 5 business days to authorize that service or reimburse on a retrospective issue. So here are the first of the 3 examples I want to share with you that enrollees have come to our help center for assistance. So the first one was an enrollee was requesting replacement of a power wheelchair that was initially denied by their health plan as not medically necessary. The enrollee appropriately reached out to our help center for assistance, and that issue was sent to our independent medical review organization. The independent medical review organization found through review of all the medical records that the power wheelchair was medically necessary, and we required the health plan to cover the replacement of that power wheelchair. The second example I've had was an enrollee who is hard of hearing was unable to communicate with their counselor because the counselor was not proficient in American Sign Language, or ASL. As a result, the enrollee stopped seeing their counselor but reached out to our help center. After contacting our help center, we were able to quickly get in contact with the health plan and locate a counselor who was proficient in American Sign Language. And so that enrollee can now appropriately and effectively communicate with their counselor to get the services and help they needed. And the final example I want to share with you today is a disabled. This happens more frequently than you might expect. And it was a recent article in a Cal Matters news article within the last week. A disabled enrollee needed dental work, but was unable to sit in the dental chair because of their disability. The enrollee's mother was trying to coordinate dental services with a hospital setting so the enrollee could be put under general anesthesia and effectively receive their dental services. The enrollee's dental plan was requiring a referral and stated they didn't have any appointments available. Upon reaching out to our help center, we were able to expedite an appointment for the enrollee so they could receive the dental services they were allowed under their evidence of coverage and receive that under the general anesthesia, which is the safest place for this enrollee to receive those services. Moving on to our internal disability advisory committee, just a quick overview. It consists of 9 DHMC employees currently. We are charged with raising awareness and advising our director on issues that impact employees with disabilities. We have, over the last couple of years, held multiple successful presentations with external speakers. And as Bobby was speaking to earlier, our current level of staff that have self-reported having a disability is currently at 13.7%, so a little below the threshold. So we've got some work to do there. The goals of our DAC are to collaborate with the DMHC's Equity and Action Work Group, which I'll get to in just a few minutes. And really, they're joining the efforts of our Equity and Action Work Group to talk about intersectionality. So there are multiple things that can impact someone adversely. It could be their race, their ethnicity, their sexual orientation, gender identification, or disability. And the more of these things you have that intersect, the less likely you are to be heard or seen. And so we are focusing our efforts not only through our Equity and Action Work Group, but through our DAC to address those issues, not only for the populations we serve as a DMHC, but also our internal staff. We also collaborate with the DMHC's Multicultural Committee. On an annual basis, we hold a multicultural event where employees of the DMHC share their cultural background, recipes, dance, and other things respective to their community or culture. It's a very highly attended event and an event that everyone at the DMHC looks forward to participating in. And then Cal HHS recently released, and I believe it was noted in the invitation here, a hiring playbook. And so we are in the process of implementing that Cal HHS hiring playbook to increase the number of employees within the DMHC who identify as having a disability. Some additional goals of our DAC are to review the Disability Advisory Committee bylaws. They haven't been updated in a number of years, so we're taking a closer look at that. And then something we're very excited about is implementing a Someone Like Me program. And so as we've moved, as most departments in the state moved in March of 2020 quickly to teleworking, and we have probably 98% of our staff currently teleworking on a full-time basis, and will remain in that high percentage of people working virtually moving forward. We're actually consolidating some of our downtown space. We're getting rid of 2 of our 4 floors, which is great. I think a lot of people like to work from home. You don't have to pay for parking. You don't have to pay for high gas prices, deal with the struggles with the traffic and congestion, but there are cons to it as well. And some of those cons are building functional relationships as a new employee to our department. And so our Office of Administrative Services, along with our Disability Advisory Committee, is trying to come up with better mechanisms to welcome new employees to the DMHC, but also make them feel comfortable bringing them in, and then building that trust not only through their colleagues, but also with their supervisor. So we're finalizing the Someone Like Me program. And what it is when we bring on a new employee, if they're willing to disclose any attributes about them, we would like to set them up or introduce them to someone else in our department who shares a similar background or experiences, so that they can have a sort of a wing person that they can bounce things off as a new employee and become more comfortable with the DMHC. They can answer questions for them, get them in contact with the right people if they can't answer that question, and build that initial trust and share our culture at the DMHC with that new employee. So something we're very excited about. Something else the DAC is working on is developing a strategic plan over the next 3 or 5 years. Where do we want to go? What things do we want to accomplish? Put some goals in that strategic plan, some timelines in the strategic plan, and who's responsible for getting those done. So that's something else we're developing. And then continue to assist our help center in assisting individual disabilities filing complaints with our help center. So we have specific staff that if someone contacts us and says, I can't fill out your complaint form, I need some help, they will work with that particular enrollee, fill out our complaint form for them, review that complaint form with that enrollee to ensure it's accurate, and then submit it on their behalf. So we're always looking at how we can do that better. So moving on to our internal DMHC Equity and Action Work Group. As a result of the George Floyd unfortunate incident of a few years ago, we decided we need to do something internally. And so we set up a little over a year ago this Equity in Action work group. It consists of staff throughout the DMHC, and the goals are to promote organizational transformation. And that, how can we be more equitable in our hiring practices, make sure that everybody has the same voice within the DMHC, no matter what level or background. In meetings, they feel safe and secure in sharing their information. And that leads into our cultivating a collaborative, inclusive, and respectful environment for all DMHC staff. Prioritize equity in DMHC's policies and procedures, and apply an equity lens for the work performed by the DMHC. An example of that would be, is there an underserved area in California that doesn't have access to specific provider types? So we would then push our health plans to increase the number of providers in that area to serve that population. So that's just one example of how we'd apply that equity lens to the work we perform. The last thing I want to talk about is our Health Equity and Quality Initiative. And as I previously described, this is a result of Assembly Bill 133 from 2021. It requires our staff to form a Health Equity and Quality Committee, which we did in February of this year. We just held yesterday our 4th meeting. The committee is charged with providing our DMHC director by September, the end of September of this year, with a standard set of measures and benchmarks that we will hold health plans accountable to moving forward. So the DMHC really has had no oversight over quality or equity until this bill from 2021. So this is a new area for us. We're very excited about it. The committee that we formed, it includes our sister departments from DHCS, CalPERS, HCI, and covered California, but it also consists of the consumer advocate community throughout California. And so we want to have a diverse group of people giving recommendations to our directors of which measures we should be holding health plans accountable to, and at what level we should hold those health plans accountable to. As I noted, the DMHC will inform plans of the selected measures and benchmarks in late 2022. We'll require the health plans to collect that information during calendar year 2023, and report that data to the DMHC in 2024. Starting in 2025, we'll be required to produce an annual health equity and quality compliance report. And that concludes my presentation. I'll stop sharing my screen. I'm more than happy to take any questions.
Thank you, Dan. That was, again, very informative, useful presentation. I know that many of the state employees belong to Kaiser plan, and there's rightfully or wrongfully the impression out there that the Kaiser not always fulfill their obligation in the way that the contractual rights are written. What role, if any, the managed care healthcare has played in correcting or adjudicating or resolving those issues on a long-term basis?
That is a very timely question, Bobby. And I didn't plant it, I promise all the participants. But yesterday we announced a non-routine survey that we're conducting of Kaiser. It's specific to their behavioral health access. Over the past, between 2020 and 2021, we saw a 20% increase in the number of behavioral health access complaints to our help center specific to Kaiser. In addition to that data, we've received concerns from the advocate community that Kaiser is not fulfilling their requirements for behavioral health access. And so, as I noted, we informed Kaiser on Monday and then informed some of our stakeholder community yesterday that we will be conducting a non-routine survey or an audit of Kaiser's behavioral health operations. So more to come on that area, but that's one way we look at through either our routine medical survey process or our non-routine. In this case, we thought the issues were so egregious we needed to take immediate action, and that's why we're conducting the non-routine survey.
And when you take immediate action, other than, let's say that you do a survey and the results are what the allegations indicate, What do you do then, and how do you, bring them back to in compliance? And the timeline, how long does it take to resolve this?
Yeah, so the non-routine survey can take somewhere between 12 and 18 months. If we find deficiencies and non-compliance with the Knox-Keene Act, our body of law, we'll refer that to our Office of Enforcement, who may conduct additional investigation, and at the end may fine the penalty, or may impose an administrative penalty on the plan and require corrective action to bring them into compliance. I believe it was in 2013, we penalized Kaiser $4 million for a similar issue, behavioral health access. They appeared to come in compliance at that time, and now we've got some issues we just need to look into.
$4 million for Kaiser is probably chump change. At any rate, you also mentioned earlier during your presentation that there were two cases you cited, one involved the wheelchair matter, the review process, and the other one was the ALS issue. How long did it take to, again, resolve these two separate cases?
So generally in IMR, that is not expedited. So it's not an urgent need to resolve that issue. It's not an immediate threat to the enrollee's health. Generally take about 45 days to resolve through our independent medical review process. The one where the example where the individual couldn't find a counselor who was proficient in American Sign Language, that generally is resolved within the same day. An enrollee may contact our help center or file a complaint. We would reach out to the plan upon receiving that complaint or phone call. Sometimes we'll do a three-way call between the enrollee, the health plan, and our help center, work through the issue and resolve that very quickly.
Okay, great. Another thing that was quite interesting and impressive is that did you say 97% of your workforce is teleworking?
Yes, currently.
Wow. And is that going to remain the same? I know you mentioned something about consolidating offices and all that, or is that number going to drop a little?
So what we're moving towards is a long-term teleworking plan. So like most state departments in March of 2020, it was a mass quick exodus from the buildings because of the pandemic, and we all scrambled to try and get working functionally in the virtual world. We were fortunate that we have a pretty stellar IT department that got us up and running very quickly. Then it was, okay, per Governor Newsom's direction to reduce state lease space, we have 4 floors in our downtown building. We assessed that space and determined we could relinquish 2 of those floors. And so what we're currently starting on is construction on one of our floors to be long-term hoteling space. And so some of our staff who might want to come in, or our divisions that want to have team meetings, can come in and do that. But long-term, I think we'll probably be close to 80–85% of our staff working at least 3 days from home.
That's still a very impressive number. I'm glad that you're doing that. You also mentioned a lot about DAC's involvement. You seem to have a very active DAC. And are they assisting or helping in any way of bringing up the disability parity rate? I keep talking about it because it's such a relevant subject for us, seeing more people with disabilities work for state service. And I know that you have different plans to improve that.
Yeah, I think one is we're trying to figure out how we can introduce the Someone Like Me program in our advertisements for open positions. And we're still working through the Someone Like Me program, but I think it would be advantageous to have that available when people are reviewing our vacancies and job position openings. So that's one way we're looking at doing it. Our Disability Advisory Committee, working with our Office of Administrative Services, trying to form, along with the Cal HHS hiring playbook. I think those are the key components for us to try and improve our rate of staff that identify with a disability.
Thank you. One question in the chat posted is, has DMHC noticed an upswing in with new persons with disability that are coming out of COVID?
I don't have any data on that. I could ask our help center for some data on that. I don't know if we've seen an uptick per se, but I'd have to go back to our help center and dig into some of the data.
Our audience is also very interested in learning. Can you elaborate more on the device that you created?
Yeah, I'll try and be very concise about this. I was working in Omaha in a skilled nursing facility years and years ago, way before the technology was available. And what I saw happening was the current method to decrease bed sores or pressure ulcers or decubitus ulcers and many different names for them is a turning schedule. And so you would have somebody placed on their back for 2 hours, you then rotate them to one side for 2 hours, and you rotate them to the other side for 2 hours, because the ulcers form from pressure and you're cutting off blood supply to tissue, then the tissue dies, and you get the formation of the ulcer. And so what I found was there was still development of ulcers. So why is this process failing? And so I started watching some of the patients in the center, and what they would do is they'd rotate them from their back to maybe their right side, but within 15 minutes, the person's back rolled back over onto their back, and no one knows about it. So in a 4-hour window, they're on their back instead of 2 hours, 3 hours and 45 minutes, and then you have this formation of the ulcer. And so I thought, well, can't you design something simply that just informs people that this is occurring? And so I jotted some stuff down on a napkin during lunch, threw it out. And then years later, in conversation with my wife, I said, I don't feel like working anymore. And she said, what are you talking? You're not quitting your job. I said, no, I'm not quitting my job. I just have this idea, and I'd like to put a time frame and a dollar limit on it. If I can't get this off the ground within a time frame or our personal dollar limit, I'm walking away. I worked with Sac State to develop their biomechanical engineering department, developed a prototype for me. I then shared that with a wound care company. They were interested in it. I teamed with them. We worked together on the formulation of the patent and further developing the device for sale. So it really is monitoring pressure, specific pressures, and then we build in different tolerances depending on the patient's presentation. And so some people can be allowed to be on a pressure site longer than others. And there's an application, an app that you can have your phone to a desktop, so it alerts healthcare staff when someone has exceeded those allowed pressures for a period of time. And so they can be back in and repositioned. And then we're working on advancing those pads that include the sensors to include maybe some wound care medication. So you're doing a dual, someone who's got an existing wound, you're presenting them with medication to help the wound heal, but you're also addressing the pressure things. So it's a press. I saw the chat that just popped up. Pressure alert system, or PASS, is the name of the device.
Thank you. And the other request, I think, from our audience is, would you mind sharing the slides that you brought with you with the rest of the group? And the way you would do that, if you wish to, send us or send me the slides and I'll distribute it if that's okay.
Yeah, I think that will be fine. I'll PDF them and send them over to you.
Yeah. Anything else that you would like our membership to know, our audience?
I just, again, reiterating our help center. So most of us on this call are covered by a health plan that's under our jurisdiction. Share the word with family and friends that if there's a denial of services or having difficulty getting an appointment or a timely appointment with someone, please reach out to the DHMC's Help Center. Our toll-free number is 888-466-2219. Again, the number is 888-466-2219, or you can go to our DHMC website, which is dhmc.ca.gov, and you can file a complaint online or print off our complaint form and send that in to us. Generally, you're supposed to complete your health plan's grievance process first. So if you've got a complaint, you contact your member services of your health plan, file the grievance with them. They have 30 days to resolve that issue. If it's not resolved to your satisfaction, or they don't resolve it within the 30-day time frame, then you can come to the DHMC. But there's a caveat to that. If it's an urgent medical issue, serious deterioration to someone's health would occur, we can bypass that grievance process. So if you're unsure, just reach out to the help center. So again, reiterating our free services that we provide that most people aren't aware of.
And some reason people are fascinated by the device. Now there's another question. Wow, that's amazing. Can you provide the app? I have relatives that are being taken care of at home that could use this. Is this available to general public?
It's not currently available to the general public, and the app works with the device. So it's medical professionals buying the device to treat their patients, and then they would use the app. So it's not like someone you would go grab off the Play Store for your own person. You got to have the device attached to it and know how to use the device. So sorry, it's not for regularly public. Could you request it from your healthcare provider? I'm sure you could. See if they could, and then it depends on the plan if they would cover it. Mm-hmm. That's the other component of this, and it's still in its infancy stages of being sold. So I don't want to overpromise things.
Have you researched into this further to see if it's covered by plans?
I'm leaving that to the company. So I've turned this over. Someone else is running that show. All
right, great. Well, so many questions about that device. It's great. Well, Dan, thank you so much. Again, this is very nice of you to show up at this forum and present and give us the knowledge that you were kind enough to share. So come back and see us soon. And you're welcome to stay on.
I will do that. And thank you for the invite. I appreciate it.
Thanks.